I want to say like the first 5 years of my career were like kind of like trying to see what else I needed to do until at one point I said, and COVID and all that stuff, I said, you know what else do I need to do? I'm already what I want to do.
Hello. Welcome to eshadowing. I hope you are doing well. Let's have some fun today. Let me bring on our wonderful guest. Let me go find her in my list. We need a different way of doing this in the future. Claudia. ¿Dónde está Claudia? How's everyone doing? Say hello in the comments. Where are you watching from? Where are you today? That is the question. I hope everyone is doing well. Had a wonderful weekend. Let me see. Claudia, if you're on here, raise your hand. Then I can find you. Easier. Toronto, Colorado, Pittsburgh. Welcome, Colorado friends. I'm in Colorado as well, if you did not know. So exciting. Again, Dr. Cortez, if you are here, raise your hand. Do. Yay. Who's excited? Hopefully we'll learn about some breast radiology today. Again, Dr. Cortez, I don't see you on here yet. If you are, raise your hand in Zoom and I can bring you on. I don't see any hands raised right now. Colorado, Houston, New York, Hawaii. Hello, Hawaii. Lots of Arizona in the house. Savannah, Georgia. Hello. Vegas, Florida, Montana for now. Hello, Montana for now. Coming to Colorado. Where are you coming? Corinne? Where are you coming to? All right. I think we have Dr. Cortez on as a... Oh, no. She declined to be a panelist. Let me try again. Dr. Cortez, let's see. Will be rejoining as a panelist. There we go. Hello.
Hi, can you see me?
I can see you. How are you?
I hit the wrong button the first time.
That is okay. That definitely happens. Right off the bat, Dr. Cortez, is that?
Yes, that's in
Perfect.
Spanish.
Yes.
People here call me Cortez. I'm fine with both.
Cortez and Claudia. Then we'll do some Espanol. Dr. Cortez, thank you so much for joining us.
Thank you for having me and for the invitation.
Yes, I'm excited to chat today about some breast radiology. Very important kind of subspecialty within the radiology world. Before we jump in, or as we jump in, one of our favorite questions here on eShadowing is, what is bread and butter breast radiology?
Breast radiology, what you get every single day are patients that are coming in for her yearly checkups to check if there's any cancer in their breasts, and that's done with mammograms. And then we also have patients that come in with any symptom in their breast. That's the bread and butter of breast imaging. We do mammogram, ultrasound evaluations. We do procedures to diagnose whatever the findings we see in the mammograms or ultrasounds. And we can also do MRI and other type of more detailed and more specialized imaging. But that's the bread and butter.
Yeah. So what's the path to become you? So 4 years of medical school, and then what does it look like after that?
Well, for me, it was a little bit different because I'm a foreign medical graduate. So I did my my medical school back in Colombia. So in case you have any medical students from other parts of the world, they might find this helpful. So I had to go a different route, maybe a little bit longer. In
Yeah.
Colombia, medical school lasts a little bit more. We don't go through college, but right after you finish high school, you go into medical school, and it's about 6 years or so. So once you're done with that, then if you come to the US like I did, I had to do all that normal US medical students do, which is the step 1, step 2, step 3, all the testing.
Yeah.
So that takes some time. So I did that. After I did that, I matched for my radiology residency. So radiology resident, you're required to do 1 year of internship. I did that. And then 4 more years of what radiology training takes, actually rotating through all the specialties of radiology. And then after you're done with that, you're not done yet. You have to do a breast imaging fellowship. So it is a long time. It's about, I don't know, 15 years or so. A lot of time, but it's totally worth it. And, and radiology is a field where you're always learning and it's evolving, and there's always new technology out there. So you really have to keep current and kind of like study all the time. I mean,
Yeah.
what else can I tell you?
Yeah, that's awesome. So, as you mentioned, you for dermatology, it's one of the few specialties kind of left that has the prelim year that you apply to separately from the dermatology residency. When you applied, were you applying specifically for a surgical PGY 1 year, transitional, or an internal medicine? Why did you choose the one that you chose?
Well, with radiology in general, I like the interventional portion of it. So, and I'm more like a surgical type of person. There's personalities out there, and I'm not one of the type that can just round for hours and discuss the thing for hours. That's a different type. I'm not like that. I like to go and do procedures and step in and do things. So I wanted to do a surgical internship. So I got that one. I did it in New York in Lenox Hill Hospital.
Okay.
So I was required to do that. But I decided to do that. You could also do like a transitional year where you rotate through several areas in medicine. But it has to fit your personality, to be honest. If you kind of find that transitioning into different specialties something appealing to you, or if you're not really sure what you want to be doing in your future, then that would be a great idea. But for me, since I knew I wanted to do more procedural stuff like breast imaging, that's why I decided to do that.
Yeah, talk about that, because that's interesting. As the field of radiology has grown, right, we have the stereotype of the radiologist sitting in the dark room all by themselves, just looking at a computer screen. But as interventional radiology has grown as a field, as more modalities are created, it does allow this specialty where if you want to be less hands-off, there are fields for you within radiology. If you want to be more hands-on, there are fields for you within radiology. Talk about that growth, because it seems very interesting, because typically if you think of like an orthopedic surgeon, you're going to be operating, right? And obviously there are non-op orthopods, but that's the exception to the rule. Radiology seems to be this really interesting field where you can do kind of a lot of different things within one scope. Talk about that.
Absolutely. I mean, and I'm biased. I know I'm not a radiologist, but for sure, radiology covers everything that somebody would like. If you want to be in the dark alone, not being bothered, and just reading your studies and finding the diagnosis, that's great. And you can get into that state of flow and just work during the day finding your diagnosis. If you want to be the other type of doctor where you're actually doing procedures and things that are really not to say dangerous, but really risky procedures where you actually have to be intervening a patient, you can do something like interventional radiology. That's something like really important that helps people, but if you want to do something like intermediate, and again, I'm biased, you can do breast imaging. And I love breast imaging because first, it has like a great impact in what you're doing. I mean, if you find a cancer early in a woman or a man or whatever, whoever comes in, you're really making a big change in their lives. You're going to really make the treatment way easier than it would be if they come in by feeling it with their hands or by the time a surgeon can actually feel it. So that's a great impact. If you want to see patients face to face, I see tons of patients every single day, new faces every single day. I'm walking into the room, I'm talking to the patient. So I do have that interaction with the patient. And of course, I also like to have my flow time. That's how I call it when I'm reading my screening mammograms, where I'm alone in the room, nobody bothering you. You're just there looking for your cancers in your mammograms. So you have like a combination of all these things in breast imaging. But yeah, absolutely, radiology is an amazing field. I know a lot of people that do teleradiology, and they can live wherever they want within the United States. They can work nights, they can work days, whatever they prefer to do. So I feel like it's still one of those specialties that give you the opportunity, although it's getting busier every time, it still gives us the opportunity to have some flexibility. As radiologists. Breast imagers is a different thing. We have to be here like in office hours. You're seeing patients, so it's not like I'm going to be in Hawaii. I can't do that. But yeah, if you decide to go into radiology, that would be a great specialty, in my opinion.
Yeah. Again, it's a little bias there. That's what I love about this field. Like once you get your MD or DO, like the world is just abundant, and there's so many specialties and subspecialties. And if you go into orthopedics and you get burnt out, like there are subspecialties that you can start to go explore and see kind of a niche patient population that may suit you a little bit better. So it's very interesting. Elizabeth asks a question that I think comes up all the time, where there's a lot of, I don't know, fear mongering, if that's a little strong of a word, that we're not going to need radiologists in 5 years, in 10 years. And I think we've been saying that for probably 20 years because the computers are coming and Google is coming with their AI. Talk about if you have any experience as an adjunct using kind of machine learning AI tools to help you do your job, or how you see that in the world of radiology moving forward.
Yeah, that's definitely something scary for everyone in all professions. Computers are now doing a lot of the things that we used to do before. But to be honest, I don't see that danger. Maybe at the beginning when they were talking a lot about AI and, maybe like 10 years ago, AI is going to, maybe we got a little bit scared, but we found out as radiologists that it's actually something that is making us read better and become better radiologists. It's not going to take our place. I mean, there's no way, I'm sorry. There's no way you're going to have a computer having that face-to-face interaction or that sensitivity to speak to a patient. First of all, I mean, that's something that a computer would never be able to do. And you need that a lot in breast imaging. As for radiology, yes, you can have things that are helping you read better, but are not going to replace you. In breast imaging, we've been having computer-aided diagnosis, for a long time, maybe since the 90s or so. And I can tell you that it's still used. I think there's a lot of opportunity for improvement. Most radiologists that I know, even myself, we use it after we read the mammogram. So I would read my mammogram, I make my impression, and then at the end of the study, as I go through the workflow, I will have we call it CAD. The CAD will just light up different areas in the mammogram. How many times do I trust the CAD alone and change my diagnosis because of CAD? Very, very rarely. A CAD is just there to show you maybe a little area of calcifications that you didn't look at or things like that. So I just use it at the end just to make sure I looked at everything, but very rarely it would change my impression of something. Now, the new aspects that AI might be helpful for us and for the patients is in identifying which patients need more additional imaging or which patients are going to be like harder cases for us to interpret. And then that's going to be helpful for our workflow because we're going to be able to decide which part of the day we want to focus on those more difficult exams rather than the more normal ones. So it's actually just helping us be better in the workflow, helping us be better radiologists, but definitely not taking our place.
Yeah, I think I love technology, and I think technology can solve a lot of our world's problems and will at some point. The analogy that I like to think about is Tesla and their self-driving cars, right? Their autopilot, they call it. I think they've been promising true autopilot for a long time, and what they've realized is like getting 90% there was really easy, but that last 10% is incredibly hard. All of the kind of far edge cases that we need to make sure are okay for driving in a car are really important. And we need that times 100 for patients. Like if a patient's life is going to be altered forever because of a misdiagnosis, because the algorithm didn't see it or whatever, like that's not going to be good, and we'll lose faith in algorithms and we'll never trust it again. So we need to get it right. And so for a long time, I think we're going to have as an adjunct, and then maybe 50 years, 100 years in the future, maybe computers will do a lot of what very basic radiologists are doing. But then for breast imaging, for going and doing biopsies and stuff like that, interventional radiology, like obviously a computer can't replace that yet.
I think so too. Yeah, it's just making our life way easier. And I can see how in the future, going through a list of 60 screens is going to be way shorter than what we actually take if this technology keeps advancing.
Yeah. For everyone watching, if you have questions, go ahead and throw them up. I'm reading the questions come up. What do you like the most about what you do day in and day out?
But I often, when I'm reading, it's funny because I'm reading my mammograms and then I just have like little sparks of joy. And I know it might sound kind of weird, but it's actually true. You know, I'm there and I put my little, I don't know, meditation music and I'm flowing through my screens, and I'm just so grateful for this job because I'm very, I have like a lot of attention to detail. So this is like the perfect job for me, you know, when I'm actually looking at things, making sure I don't miss something, analyzing differences between the previous year and this year. So that's something that keeps my mind kind of like stimulated. So that's something that I like about my job. Of course, I love the patient interaction and what I told you, that you're really making a difference in patients' lives. So that's a given. But now that I'm more like in a leadership position within radiology, I've also found it very motivating in some way. You know, when you have to take care of more people like you that are part of a team, I like that a lot too. I mean, I feel like when you have the responsibility of having other radiologists have happy lives and be happy with what they're doing is very rewarding. So that's another thing that I like about my job right now.
Yeah. What led you to radiology to begin with, and then specifically breast radiology?
Well, my family, I mean, there's a lot of doctors in my family back in Colombia. So my grandfather was a doctor, my aunt was a doctor, my dad is a doctor, and my dad happened to choose radiology. So I grew up with radiology. I knew what it was. I knew what my dad was doing. I would go to his reading room and see him reading his, back in the day films and all that stuff. So I was familiar with it. So that's why I wanted to go into radiology. I basically did medicine and I knew that it was very likely I was going to end up doing radiology. Of course, I wasn't just closed into that. I wanted to experience other areas, and that's why I did, surgical stuff, and I liked surgery. But at the end, radiology won, and I thought 1 year of internship was going to be enough surgery for me, and it was. My ideal work would be maybe being a breast imager / breast surgeon. That would be like a beautiful thing to do. Like you would just read your mammogram, operate the patient. But no, I'm happy with breast imaging, and specifically breast imaging because of all the reasons I said before. But also I've noticed that a lot of people that decide to do breast imaging, they usually have something else inside that made them want to do it. in my case, my mom was diagnosed with breast cancer when I was in medical school. So that was like, yeah, this is what I'm going to be doing. Somebody saved my mom's life because they found her cancer very early.
Yeah.
So, I mean, I saw it really close. And if you think about it, I think everybody knows someone, either close person or someone, close friend, family member that has had breast cancer. So yeah, it's easy to make that decision when you see the impact that you may have.
Yeah, definitely. Talk about the work-life balance as a breast radiologist. Do you feel like you have enough time for life outside the hospital now that you're an attending?
Yes, I do have time. I have to say
there's a little hesitation there.
No, I think it's, I'm not attending now, but you always feel like, oh, when I'm not attending, I'm going to have time to do this or that, or I'm so busy when I'm a resident. It's a different type of busy, I feel like. So you're still busy, but I have a family, I have kids, I have a husband, I take vacation time. But I feel like once you're out of residency, I don't know if this happens to other people. I feel like people that study medicine, we're used to doing like every single thing like on steps. So first I'm going to do this, then I do the test, then I do that, and then I do that. And then after that, I do the internship. And then after that, the residency. And then you're always like in this race of finishing things. Yeah. So once I finished, I was like, okay, now what? So now I'm going to start working more, and I'm going to do more things, and I work more, and then I work more. So I want to say like the first 5 years of my career were like kind of like trying to see what else I needed to do, until at one point I said, and COVID and all that stuff, I said, you know what else do I need to do? I'm already what I want to do, So now it's like I'm learning to just take time to do other things as well, and if you have some time off, enjoy that time off, and you're entitled to that. I feel like I've always been racing, doing everything I have to do step by step. And a lot of my medical school friends are like that. We're all doing step-by-step things. And sometimes you just need to breathe. Sometimes it can be a breathe because of COVID happens. And then everybody stops for a little bit. And then you consider your life and what you're doing. But I think it's something that we all need to learn. We all need to learn how to balance things. It takes time, especially when you're coming from that race.
I love it. I think I was pretty good at not running the race and just enjoying every step of the way. Unlike you, I didn't have anybody in my family that were doctors. And so I came into it very ignorant and naive about this whole process. And so I'm just enjoying every step of the way. I think it kind of hurt me in some ways as well. But the intentionality of kind of living day by day and not just chasing the goal of like, okay, once I do this, then I'm set. Once I do this, then I'll be happy. Once I do, like, just enjoy today. That's okay. That's okay.
Yeah. Or also kind of like reward yourself, because you just keep thinking about that next thing. And then you never take the time to say, I did it. And I'm just going to celebrate that. If it's a 4-day weekend, or if I'm going to take a week off, but just give yourself a pat in the back and say, yeah, I did it and I deserve this. You just feel that you're deserving of that pause and that rest.
Definitely. You mentioned COVID as a potential break in there as well. Do we have any data yet from a breast imaging standpoint where patients delayed breast imaging and now they're being diagnosed with later stage disease? Is that going to have some ramifications for a couple of years to come?
Absolutely. And that's one of the problems that we saw with COVID. No, it was not just like, I have lymph nodes because of the vaccine, which was a big thing. But the biggest thing that we're noticing is a lot of patients that delayed their diagnosis. So if you think about it, it was like a year of people not getting their imaging, first because we didn't know what was happening. We didn't have the equipment to protect ourselves or protect our patients. So a lot of places had to shut down for a little bit. So that's one thing. But then we also had patients that didn't want to come in because they were afraid of getting infected. So yes, absolutely, we're going to see those numbers rising up. And that actually is bringing even more the disparities that we have in breast imaging more into light, because a lot of those patients are uninsured patients or patients that have no really good access to healthcare. So it increases those disparities a little bit more. So yes, it definitely has an impact. And it would take a while for us to see those numbers climb, unfortunately, but we'll definitely see them.
Yeah. Are there, and I don't know, I think it was the Good Morning America or the Today Show host who was diagnosed, like, just like, I'm going to get a mammogram for TV and show. And then she was actually diagnosed having breast cancer. I believe that was on a mobile screening unit. Is there potential of like, hey, we understand there's some disparities here, or maybe we should buy some more of these mobile units and get out in the community?
Absolutely. And I think that's a great resource that we can use. Before I was working here at UT Health in Houston, I used to work in a nonprofit organization here in Houston as well. And they have like 4 mobile units that go many different places in around the Houston area. And the amount of patients that you would see in those mobile vans, I mean, it's crazy. And if you think about it, they're so far, it's really hard for them to get into the city to get their imaging done. And even that, you know, sometimes we take it for granted, but transportation is a really big issue for patients who have low incomes. You know, they can't get to places. So bringing the mammography to them, and that's the beauty, you know, it's just a van that has the mammo unit in there.
Yeah.
That can help a lot with the access to patients. And definitely, I mean, I wish there were more nonprofits like the one I used to work with, because you really see how many patients need places like this. You'd be surprised. You know, I was like, oh my goodness. I mean, this is a lot of patients that need help. And I was happy to be able to help them for the time I worked there.
Yeah, that's amazing. What led you back into the academic world to wanna be in academics and teach and do all that fun stuff?
Well, many things. I was in this. It was called The Rose. It's a nonprofit. It's still out there. It's great. And I was working there for a while for many reasons. First, I'm Hispanic, and a lot of the patients that are underserved or uninsured here in Texas are Hispanic, you would guess. So there's a lot of disparity there. So I felt like I was kind of giving back in some way. You know, when you're like a foreign medical graduate, I feel like a lot of us feel like I want to go back and help my country or my people and things like that. But then I found that way to kind of heal that place I was in. So I'm going to help this patient population for a little bit. And I was there for maybe 6 years or so. I loved it, but I've always liked academics, always. So even while I was there, I would take my free time to send little, I don't know, exhibits to this conference or go to another conference. So it was always there, you know, calling me. There was a point also with COVID, you know, we started thinking about our lives. And I was thinking, you know, what do I want to do with my future? Like, how do I see myself? And I have like this feeling, I had that feeling that I wanted to keep growing or keep learning. I'm a very curious person, so I wanted to keep learning. And I felt like I was lacking that a little bit there. You know, we see a lot of patients in the rows. We had a lot of patients, but we were not a lot of radiologists. So I was basically by my own all the time. So I needed that type of connection with other people in my field. So that's when I decided to go back into academics. And then, of course, having the opportunity to teach others to do what you're doing, we're so needed. I mean, seriously, radiologists, we are so needed. And right now there's such a shortage of breast imagers that being able to have people decide to do breast imaging has been super rewarding to me. Like in my first year, I've had already 3 of the residents tell me that they want to go into breast imaging. So that's amazing, you know, because you're really making somebody change what they wanted in their life because of the influence you're having on them. So it's very nice. I'm actually very motivated in this job that I'm in right now.
Yeah, most of the physicians that I talk to through the various channels where I'm interviewing doctors, it seems like a mentor similar to yourself is the one that got them interested in a field. And it's very interesting. And I don't think students understand the power of that mentorship. So for everyone watching this, listening to this, like go find a mentor as you're going through this. And that their specialty may be your specialty in the future. You never know.
Yeah.
That's awesome. So April has a question. As a non-traditional medical school applicant, she's 32. How is breast radiology for an older, non-traditional medical student?
I think it should be the same as for anyone else. If anything, it would. I'm thinking it might be good, because when you see women, we start seeing women here at age 40 regularly. Of course, we see younger women also, but I feel like for a patient to see an older or more mature looking person, it might be actually helpful. It might be actually something that they're going to feel more comfortable with. A lot of women like to see, have that empathy with their doctor and try to see if they relate to each other. So I think it doesn't matter the age at all. I think it's actually going to be helpful.
Yeah. There's a TikToker medical student who just announced on her page, she's 50, 51 maybe, as a medical student. She was just diagnosed with breast cancer and is gonna have a mastectomy. So she is experiencing medical school and the breast radiology and breast surgeon world all coming to a core. So maybe breast radiology is in her future as well as somebody potentially impacted by this. So we'll see. Again, that's the road to Dr. Jen on TikTok if you want to go find her. Amy has a good question. We were talking about some disparities earlier. She said, even after controlling for lifestyle factors, SES, access to care/screening, etc., research seems to show that African-American women have more aggressive forms of breast cancer than their white counterparts. Can you speak to that?
Yes, it's true, unfortunately. Breast cancer has a lot of genetic factors to it in some way, and some cancers can be very aggressive and appear in younger women. And one of those is triple negative breast cancer, and it's more common in the Black community. So yeah, there's a lot of disparity there. Can you do something about those genetics and all that? Not really. You can't really change it. But what it's interesting for me to see also with the Hispanic community is that even though the incidence of breast cancer in African American or Hispanics is lower than whites, these patients are detected later and die more from breast cancer. So you see there's like a disbalance there. And a lot of it, I feel like it has to do with probably patient literacy in healthcare, what they know about the disease or what ideas they have of getting their screening mammography. So I think there's a lot of options for us to help in that sense, and try to communicate patients what they really need and how to get empowered of their health and know what they're supposed to be getting at every stage of their lives. Some women in the African American community are actually, we actually recommend that they start screening earlier, or sometimes they need to get like genetic or high-risk clinic consultation to see if they're going to be in this high-risk category so that we can do additional imaging for them, like screening MRIs as well. So there's a lot of things that we need to keep learning and keep telling our patients, because it doesn't make any difference if we write papers about it and nobody tells women, so
you write papers about it that the distributors charge $30 to access.
Exactly.
That you don't get anything.
No, and if you type it as a regular patient, we know how to do a literature search, but if you have a regular patient going to Google, they're going to have like, I don't know, what is it, WebMD page, something like that.
Yeah.
But we actually need to take the information we have in the medical field and distribute it to our patients in a way that they can understand it. And we suppose people understand every word we say, and it's not true. You have to say it in a way the patient really understands what you're saying so that they can really change their lifestyles and get their required imaging.
Yeah. And things like having a mobile unit that can go to their community and be there and show them that it's not scary and explain to them, and they can see their community participating and they'll go, oh, okay, I guess it's not scary. It's
absolutely. And see more people like them getting
it.
Or more people like them being their doctor, so yeah, absolutely.
Yeah, that's huge. What do you like the least about your job?
What do I like the least about my job? Maybe the sense of urgency. When you're a radiologist, like a resident, and you're like there reading body or reading things like that, where you can just step out and have a coffee and come back and then go have lunch for a little bit and then come back. You don't have that in breast imaging as much, so that's something, maybe one of the downsides of it, since you're seeing
why not?
Because you're seeing patients like a
because you have clinic. Yeah. Okay.
So you have a schedule, you have your patients showing up. Sometimes you have different patients showing up at the same time, and you can have maybe 3 techs working for you doing the imaging, and they'll call you at the same time. So your phone is always ringing. You're like, okay, what is it? And then you have to flip from one to the other. So it can turn a little bit hectic sometimes. So it's that sense of urgency, like you have to be there.
Yeah.
You can't move. So if I go out and step for coffee, the patient is like, techs are waiting, or then, like, where are you? Or then you come back to the room and you have a line of 5 techs tapping their toes at you. And you're like, So that's probably the only thing I don't like as much. But you learn how to navigate that. So I do go and drink some water.
That's good. Yeah, my wife, who's also a physician, will often come home from a long day of clinic, and she's like, "I don't think I peed all day." I'm like, "That's not good. Like, go take a pee break."
Seriously, you can get into that habit, or you can get into working through your lunch, and those things start like burning you out. So that's what I was telling you. You have to learn how to balance those things, because if you don't, you're going to burn out yourself very quickly. So if you see that you're in a job where they're just putting patients on your list and there's no lunch break, and that you have to say, hold on one second. We need to eat. We need to go to the bathroom. So you can manage those things, and you'll learn how to do it.
Yeah. So explain to me, I've never had a mammogram. Some men do. I've never had a mammogram. I think some people listening to this, Samantha says she's 27-year-old African-American woman, had her first mammogram last year. Hearing you have clinic, when I think of mammograms, when my wife has gone, other people have gone, it doesn't seem like they see a radiologist then. That's just the tech, and then we get a read later on. What are you doing in your clinic day that requires you to interact with the patient? Okay,
so what you're describing is the screening mammogram. So, a screening test is just something that the patient would get, and they would tell them, good, no cancer, or something suspicious, we have to work it up. So that's a screening. You don't need to see a doctor for that. You just walk in, get your mammogram, walk out, right? If you have a problem, let's say you feel a lump in your breast, or you have some weird pain in your breast, or you notice a change in your skin or nipple discharge, all these symptoms that you may be having, or if one of us called you back because we saw something in your screening mammogram, we're going to call you back as a diagnostic study. So you're not going to be a screening patient that just comes in and leaves. You're going to be our patient for that day as a clinic. So you would come in, you'll have additional imaging. Sometimes we need to repeat some of the images to see if the finding is real or not, or compress it a little harder, or magnify it to see if there's little pieces of calcium in it. Yeah, we do.
Squish it. That's what I hear is the worst.
We do all these things just to see, okay, if it's real or not.
Yep.
After that, we might say, well, we need to do an ultrasound to see what that mass is, what the shadow that we're looking at is. Then the patient would have an ultrasound. It's a technician that does that. While all these things are happening, we are the ones calling the shot in the reading room and saying, she needs this, she needs that, she needs that, da, da, da. After they do everything, they'll call us back, the techs, and they'll say, this is your patient, this is what we did. And then you make the assessment. You say, well, that mass looks suspicious, or that's just a cyst, it looks good. You would go into the room. I personally like to scan my patients. A lot of them I just overscan and see, because ultrasound is a modality where, depending on who's doing it, things will look in a different way or so. So while I'm talking to the patient, I have my patient there, I'll just be scanning, looking at it, and deciding in my mind, what am I going to do with this abnormality? Or if it's nothing to be worried about, which most cases are nothing to be worried about, fortunately, we can tell that to the patient and explain the reason why they're having the pain, or why they're feeling a lump. It's a lump, but it's a benign lump, things like that. So that's what we're doing in between. So a lot of patients will be going into that screening room, while on the back end, we're doing all these diagnostic patients like in a clinic format.
Yeah. I'm on faculty here at the University of Colorado School of Medicine and help teach a communication course for first and second year students, part of that breaking bad news. What tips do you have for having those more serious conversations? Because I'm assuming, again, the patients that you're seeing are past the screening stage. There's potentially something wrong. So they're already coming in with heightened anxiety. And then they see you, and you have to break some bad news to them because it is something potentially worse than just a cyst. What tips do you have for a student to start learning how to do that?
What I can tell you is that when I was a fellow, it was a little hard for me to kind of find the way, because you don't want to give bad news. I mean, that's a horrible position to be in, but it's a position that we are very often in as doctors. So what I did as a fellow, I seriously wrote a script of what I would say to the patient, because I didn't want to just sit there with no words at all. It would be very uncomfortable to just be sitting there and staring at it, not knowing what to say, right? So I did write, and I'm sorry, there's a lot of noise.
That's okay.
The medical
Yeah, I like it. It makes it real.
It's not breast imaging patients for sure. It's not a breast imaging emergency. But yeah, I did a script. So at that time, when I was a fellow, I was giving or breaking the bad news via phone, which is not the ideal way, but sometimes you have to, you can't have every patient coming to see you. So I would have a script, and I would say, good morning, Miss So-and-so. Is this a good time for you to talk? This is Dr. So-and-so. I saw your mammogram, or I did your whatever, and I just give them some context. Are you ready to take this call? And they say yes, because they might be driving, or you don't know where they are. And if you're going to be giving bad news, you don't want them to be, driving or something. And if they tell you yes, then you go ahead and say the bad news. I've found it helpful to pause while I'm saying this, not just like, well, we did your biopsy and it did come out as cancer, so whatever. No, you have to just, hey, remember your biopsy. I don't have good news for you. Unfortunately, the area was cancer. And then you pause and give them some time to digest what you're saying, because sometimes they don't even understand, or they don't want to hear what you're saying. So give them that space. You can repeat it again. You can tell them, do you have any questions? And the other thing that is also important for every patient that you have an encounter with, in my opinion, is to have what's going to happen next to tell them. Because if you just call someone to give them bad news and you're not telling them what the next step would be, like, what do I do with this? Like, now what? And then this patient is going to be completely, feeling useless. So I like to have a plan, and I would tell them, we already contacted a surgeon, or you're going to have a nurse navigator contact you and tell you what the next step would be. You're going to probably need a MRI. You're going to see a surgeon. We have everything planned for you. If you have an appointment date, give them the date. We have an appointment to see you. If you want to come and talk to me personally, you can always come in, and you can find the time to do that. So always have a plan for them to follow, and just know that maybe next time they come in, they probably forgot everything you said, and they're going to have all these questions for you again. Just be patient and understand that that's like shocking news. Of course, empathy is a given. You have to know what the patient is going through. And if they're crying, give them the time to cry. Don't tell them it's okay. No, you don't know if it's okay. You don't know if this patient is going to die from this cancer, right? But you can tell them, if you caught it early, tell them, I feel like you're going to do good. This cancer was caught very early. I'm very, very, hopeful that this is going to be okay. You can tell them things like that if you really are. But if you're not, then don't tell them they're going to die. You don't know that. But you can tell them, I think this is a very serious thing, but we're going to work together to find the best way to treat this for you, or something like that. Always give encouraging words, and give them the time to process and to feel whatever they need to feel at the moment, and be prepared, because sometimes you can have patients that are will get mad at you, or patients that would be mad at the world, or they will just cry and scream. And just know that that's not towards you. That's just a feeling that they're having in that moment. And it's totally unrelated to what you're doing. And it's not your fault. I mean, it could never be. So you have to kind of like find that space. It took me a while, I have to say, to be able to give this news, especially when I was working in that nonprofit, because I had to give this news in person, which is harder, I feel like. But you can find the way to kind of, and I don't want to say disconnect, but just have empathy, but don't let it get into you and sink in with you, because you can get really depressed sometimes. There are some cases that are really, really sad, and you can be sad, but don't bring it with you every day to your house. You know, you have to
take a breath.
Right.
If anyone wants to come on and ask some questions live, go ahead and raise your hand, and I'll allow you to turn on your microphone, come ask a question. I want to ask a question. It's a little bit more in the weeds as a follow-up discussion to breaking bad news, is the unintended consequences that I think physicians saw was going to happen, but lawmakers didn't, with open notes and the whole legislation around patients need to be able to get their results and notes and everything immediately. There are people sitting at home getting an email going, hey, you got a new note in your chart. And then you go read it and it's like, I have cancer. Why didn't my doctor call me? Is that affecting your world at all?
It does affect. I think we all have the right to be able to see our tests and all that, but it's important for you to research and understand what you're reading. What I do with my patients, I tell them, you might get this news before. If you have any questions, please give me a call. If you don't understand what you're reading, please call me. I always open that door. If it is a patient that I think might be having a cancer, you know, as breast imagers, we can kind of like say the degree of suspicion we have for things. And if I know this patient is a BI-RADS 5, for example, and that means that this patient has a more than 95% chance of having a cancer, I kind of prepare the patient for these kind of news. So when they open it, they're not like, what? I didn't know this was, you know. So I tell them, when I'm doing the biopsy or the day of the biopsy, usually after the biopsy, so that they're not very nervous, I would tell them, hey, you know, I am very worried about what I see today. I don't tell them I think it's a cancer, but I tell them I am very worried and I think we need to act on this very quickly. So let's do this biopsy. Let's wait for those results. Even if it's not cancer, I think this needs to come out of your breast. So I'm telling them in some way, you're going to need a surgery for this, right? I'm kind of preparing them a little bit so that when they read those reports that say carcinoma, they kind of know, yeah, the doctor did tell me she was worried about it. And of course, open for questions. If you have any questions, give me a call. So yeah, we're kind of like in that race to try to call the patient before they open it. Sometimes it's impossible. And it's just part of the job now.
Yeah, it's unfortunate. Whit has a question. Let's see if Whit can unmute. Hello there.
Sure can you hear me okay?
Yep.
Fantastic. Thank you very much for this fantastic discussion and for your time today, of course. You've given some amazing insight into delivering pretty challenging news to patients and just how to work with them on that. That's just been incredibly valuable. I'm curious, and this is on a much lower level, but I'm curious what lesson you've learned over the past however many years that you wish you would have known when you were a pre-med, whenever you were starting down this journey, and kind of what you ran into there that might have changed things or not changed things for you, but just might have made the path a little bit easier. Thank you.
Thank you. So the question you're asking is, what things I would have changed during this whole path? Is that the question?
Yeah, kind of what do you wish you would have known as a pre-med that potentially would have changed your path? And again, it's a little bit different as a international medical grad. You are pre-med in another country.
It's also kind of like the same, you know, and it goes along the lines of what we have discussed. I wish I would have understood before, like when I was younger, that you should just have fun while you're doing it and don't take it too serious sometimes. One of the things I regret the most, and I think about it often sometimes, I'm like, oh, I should have done that, is to kind of like have a year abroad or travel in between studies or have like a little break, you know. I felt like I just finished high school and grew up and became this doctor. And then I see my sister or my brother, they went a year abroad, they learned another language, they did other things, they learned other cultures. So I think sometimes when you are like in this serious mood of becoming a doctor, you forget about those things. So if I would have done anything differently, probably maybe taking some longer period of time off to visit a different country or learn a different culture. I think the value that that brings, it's really incredible. For me, though, being an immigrant, I bring that with me. You know, I am the different culture. So I have that asset of being a little bit different that helps you with other patients or seeing patients that are similar to your background and all that. But I don't know if that would answer your question, but I think all medical students are very responsible and they know what they want to go for. My advice would be, if you can and you're young and having fun, have a little fun, you know, just is a year more. It's not going to make any difference in your life at all. At all.
Yeah. Yeah.
So I was like, oh, it's 15 years to be a breast imager. So I have to do it now because then I'm going to be 35. You know what?
Yeah.
1 year difference. It's not a problem.
It's a big message that I have on all of my channels of just going out and just enjoying yourself and doing what you want to do versus doing the things that you think you have to do to get into medical school. I think too many people carry that mentality, which I think makes them a little bit upset and jaded. And this is where we get these strong words like, I wasted my 20s to do this. I'm like, you didn't waste your 20s. You just spent them differently than your friends and your peers. Like, my best friends are from med school. I had the best time in medical school. I met my wife in medical school. Like, I lived my life in my 20s. And so it's just a little bit of a change in mentality of what you're allowed to do. I think not enough people give themselves the flexibility and freedom to know that they can do these things and still be successful on the other end.
Absolutely. And if there's an option of you doing like a rotation or something abroad or go somewhere else, do it, you know, do it. And actually that's gonna, now that I'm in this position as an attending, that would be more appealing to me when I see someone that, oh, he did a year abroad doing so-and-so somewhere else. Oh, that's so interesting. You know, like that gives you an extra, you know, spark, I feel like. So enjoy those years.
Well, Dr. Cotez, thank you so much for joining me today and sharing the breast radiology world with our close to 200 people here today. So hopefully we have some future breast radiologists in the mix to hopefully go save some lives in the future.
Absolutely. We're superheroes. Another type of superheroes here.
Yes, you wear a white coat and a cape when you are doing your biopsies and ultrasounds and all of those fun things. Thank you so much. And thank you everyone for coming and hanging out. We'll see you guys soon. Bye.
You're welcome. Thank you. Bye-bye.